Good morning, ladies and gentlemen. Today, I'm very honored to share our studies on OSA-associated hypertension. It is widely known that OSA is one of the most common sleep-breathing disorders, and also it is considered as the most cause of secondary hypertension and resistant hypertension. And a literature-based study has reported that it is estimated that there are nearly 1 billion adults aged 35 to 69 years with OSA globally. And in China, it is estimated that 170 million adults OSA in China. It is common that OSA is associated with metabolic disorders and cardiovascular disease. And from this picture, we can see that the OSA and the cardiovascular disease and metabolic disease, they share some common mechanisms. And this table just shows the prevalence of OSAs in population with cardiovascular disorders. And it is noticeable that in patients with hypertension, there are 30% to 83% of patients with OSAs. This is the data from our hypertension center in 2010. We may notice that in the hospitalized patients, we have 25% of OSA. And this is the latest report about from China. It included patients from 1,746 tertiary hospitals in China. And it concluded that the renal peritoneal disease is still the most common cause of secondary hypertension, but it is with a decreasing trend, but followed by the OSAs and with an increasing trend. So this data may show that more and more physicians pay attention to the identification and treatment of OSAs. It is widely known that if a patient with OSAs may have the elevated morning blood pressure and elevated nocturnal blood pressure, and our center data just show that if the nocturnal diastolic blood pressure is associated with moderate and to severe OSAs in hypertensive patients, and it has a good diagnostic for hypertension patients to identify OSAs. If tandem with no opinion model, it can improve the ability to diagnose moderate to severe OSAs. But it's not enough. From this picture, we can see that the 24-hour ambulatory blood pressure monitoring can display as normal dippers, reduced dipper pattern, or even reverse dipper or extreme dipper patterns. So if for patients with hypertension, we can not only diagnose OSAs just by the ambulatory blood pressure, but we notice that OSA patients will have more non-dipper and reverse dipper patterns of 24-hour blood pressure rhythm. But our study on the nocturnal blood pressure, we notice that OSA not only affect the nocturnal blood pressure variabilities. Our data found that the diurnal and blood pressure variability also increased and associated with oxygen decrease and the sleep stage. But the effect of OSA on the long-term cardiovascular outcomes is not consistent. And this meta-analysis just shows that OSA was associated with a higher risk of hypertension, diabetes, and cardiovascular disease, but has no significant association with all-cause mortality and cardiovascular mortality in adults. So in order to explore the relationship between the OSA and the long-term cardiovascular disease, our hypertension center just conducted a retrospective cohort study named the Urumqi Research on Sleep Apnea-Associated Hypertension, URASA study for short. And our study was studied from January 2011 to December 2013, and we included a total of 3,600 consecutive hypertensive inpatients with suspected OSA. And we had a median of 7 years follow-up, and finally, there are 3,329 patients was included for the final analysis. And the next, I will show our findings. At the very first, we found that there is a non-linear relationship between the Chinese visceral adiposis index. It is significantly associated with the risk of new onset myocardial infections, but it's a non-linear. And then we just find the cardiometabolic index, CMI, is correlated with the new onset cardiovascular disease in patients with hypertension and OSAs. And also, we just use the higher triglyceride glucose and with the circumference index to evaluate the association between the first myocardial infection. We also found a mild G-shaped curve and between the index and the risk of first myo index. So our index just shows that for patients with OSAs and hypertension, maybe we need the new indicators to predict the diagnosis of cardiovascular disease. And this latest study about the OSAs and heart failure, it is from the United States studies. It shows that OSA in patients with heart failure with preserved ejection fraction, it is associated with greater mortality, longer hospitalization stays, and higher medical costs relative to findings in patients without OSAs. But we also noticed that the nocturnal CPAP was only used in 9% of patients and with no difference in arrhythmiogenesis. And another finding of our UROSA study is that BMI is positively correlated with cardiovascular events, and with the increasement of body mass index, the risk of cardiovascular events will increase significantly. So our data just emphasize that the importance of maintaining a healthy body mass index to prevent adverse CVDs. The bidirectional relationship between OSA and type 2 diabetes is very clear, and this meta-analysis just shows that besides of CVDs and chronic kidney disease and all-cause mortality compared with patients without OSAs, the patients with the strategies to detect OSA and prevent cardiovascular and macrovascular complications of diabetes should be implemented. And in our UROSA study, we also find that for hypertension patients with OSA, the non-dipping blood pressure pattern is associated with an approximately 1.5-fold higher risk of new onset diabetes. But the relationship between OSA and the serum uric acid is inconsistent, and no relationship was observed between uric acid level and OSA severities. But the latest meta-analysis just shows that the serum uric acid levels were generally elevated in OSA patients, and it may be a potential risk factor for the development of hyperuricemia and gut. And the last metabolic disorder is concentrated on the homocysteine concentrations. In our UROSA study, we just found that elevated plasma homocysteine concentrations are associated with the risk of the first ischemic stroke, but it's a non-linear relationship. So from the above information, so we noticed that the OSA showed a very effective on the cardiovascular disease, but it's a pity that just one third patients choose to treat OSA, and there are many patients that did not treat OSAs. So, 2 years later, 2 years before, the AHA just published the scientific station, and it pointed out that the OSAS is often under-recognized and undertreated in cardiovascular practice, and more attention should be paid to the identification and treatment of OSA. But it's difficult during our clinical practice because the mechanism of OSA is not clear, and the pathophysiologies between OSA and cardiovascular disease is also not clear. Usually, it refers to the mechanical, respiratory, inflammatory, autonomic, and hormone factors. And considering the clinical heterogeneity of OSAs and the mechanism of OSA needs different research perspectives as like risk factors and environment, clinical pathophysiologies, biologies, and genetic levels. And our cohort and our team just rethinks the reason of OSAs, and we noticed that from this picture, it compared the patient of the endothoracic pressure between normal person and the patient with severe snoring. It noticed that the pressure in the endothoracic is deeply decreased, and this decrease will cause the influence of will cause the affecting of protein of sufficient secretion. So we have said that the lower airway may also included in the mechanism of OSAs. And then we did some research about the lower airway resistance and the decrease in active substance. And we found that for the patients with OSAs, their resistance of lower airway is increased, and the active substance such as sufficient protein in the serum just lower. So our hypothesis is that if the sufficient protein lowered and the resistance of lower airway increased, and which caused a collapse of the upper airway, and then the OSAs occurred. Another research about the mechanism from our team is that microbiology change, and our study found that the diversity of oral, pharyngeal, pulmonary, and intestinal microbiota in OSA patients is reduced compared to those without OSAs. The intestinal barrier is disturbed. The concentration of related inflammatory factors is significantly increased, which is indicating that OSA patients have a dysbiosis of the microbiota. And the last point I'd like to share is OSAs and the primary aldosterone and the high aldosterone levels. It is widely focused in recent years. And this table just shows the prevalence of OSA in PA patients. And this table just shows the prevalence of PA among OSAs. We can notice that both of the disease always combined together, and there is a very strong interaction between OSA and PA, and it is associated with hypertension in OSA patients, especially in refractory hypertension. So our latest reports from the URASA study that we reported the prevalence of primary aldosterone is significantly higher than that of non-OSA population, and the prevalence is 13.2% versus 10%. And this is in the general specific analysis, the prevalence of PA in male hypertensive patients with OSA was significantly higher than that in non-OSA patients, but no difference were observed in the female population. And further, we just analyzed the concentration of plasma aldosterone. We noticed that with the increasement of plasma aldosterone concentration, and the survival probability will decrease. And the cut point of plasma aldosterone concentration is larger than 12.5. The mechanism between OSA and PA is complex, but some hypothesis is suggested. For example, the OSA caused the intermittent hypoxia as the RAS system activated, and then the aldosterone secreted very good higher. And on contrary, for a patient of PA, the aldosterone increased, and the sodium water reabsorption will increase, then the pharyngeal edema and the cause upper airway obstruction, and then OSA occurs. So the PA screening has become one of the hot topics of hypertension research in the future studies. And at last, I'd like to give a summary. Although OSAS has a strong association with cardiovascular complications and metabolic disorders, it is often underdiagnosed and undertreated in the clinical practice. And considering the clinical manifestation of OSAS are highly heterogeneous, and its pathogenesis needs to be studied from multiple perspectives. Anyway, our conclusion is that OSA needs more attention. So thank you for your attention.